We'll wrap things up, but first I want to introduce Dr. Olga Toleva, who was born in Bulgaria and became a doctor at the Medical University in Sofia. She did a family medicine residency at UBC and UBC internal medicine program. In 2009, she moved to the University of Alberta and did a cardiology residency program, followed by the interventional cardiology fellowship program. Then she went to Harvard, to the Public School of Health, for her Master's of Public Health on clinical effectiveness. And then after 2 years at U of A, she did 2 more years of interventional cardiology there. Then she moved to St. Boniface Hospital in 2014. She became one of their interventional cardiologists. She spent most of her time in the cath lab, and if you've ever had an angiogram, since 14, you might have actually met her. I've had a couple of them, but we never got the chance to meet. She also implants stents. She's also been doing state-of-the-art research on TAVR, which is described by the American Heart Association as this minimally invasive surgical procedure repairs the valve without removing the old damaged valve. Instead, it wedges a replacement valve into the aortic valve's place. The surgery is called TAVR, transcatheter aortic valve implantation. Impress your friends with that. Let's hear from Dr. Olga Toleva.
Good evening. This is a great pleasure for me to be invited in this beautiful auditorium with predominantly women. First of all, I have to thank you for the introduction and for the great stories I heard from patients and their families. These are always very touching because I'm one of those people that meets the family at the door when someone comes in with a heart attack. They're sick, they're scared, they're confused. And this is the time where a good word and just a simple word really helps and makes things clear. For example, I was on call this last weekend in the cath lab. I'm one of the 7 cardiologists that performs angiograms and stents, and also am on call whenever there is an emergency. We have a coverage for 24 hours, 7 days a week. If someone needs an angiogram, we're there to perform it. I did about 15 emergency angiograms in this last weekend for people who were having acute heart attacks, who were really, really sick, and I had to talk to their families. And I really feel for all of you that are here, the ones that are survivors, the ones that are family members. This is a very important night for me to tell you a little bit about what we do at St. Boniface to help you and your families survive and learn about heart attacks. The first thing I wanted to talk about is to tell you a little bit about the pathophysiology of how the plaque formation happens. It was very interesting in the talk that the women and men are very different in the way they actually form and build plaque in their hearts. We're different and still we're similar in a certain way. The first years of research showed that men were predominantly the ones that developed blockages in their heart arteries, and most of the research was actually done on male patients. So the first information we had about atherosclerosis was basically and predominantly done on male patients. For that reason, for many years, we actually were not aware what happens in the woman's heart. Is it the same? Is it different? And then in the early 80s, we realized that women also get heart attacks. For the longest time, we believed that women are protected because they have estrogen on board, and for that reason, they don't develop heart attacks. And if a woman complains of a chest pain or angina or similar symptoms, it was attributed to other problems, anxiety, stress, depression, and more often was ignored. In the 80s, we realized that women also have heart attacks, and the big fear came when we realized that more women died than men from heart attacks. And that's when we started doing more research. With advances in coronary angiography and imaging, we realized that women develop blockages just like men after the age of 65 when their estrogens lower down. But also, young women could develop heart attacks, and there are some other pathophysiologies that are completely different that we were not aware of before. For example, a woman will come with a heart attack to the cath lab, and when we do an angiogram, we don't see any blockages, but yet we see very big damage. This is a syndrome known as a broken heart syndrome. It usually is associated with the female sex and also extreme stressful situation. At that point, the release of adrenaline and the stress causes vasospasm in all the microscopic arteries and a huge damage caused to the heart muscle without any evidence of blockage and without need for stents or coronary artery bypass grafting. There is another entity that we started discovering in the last 10 years, and in fact was well described by a Canadian interventional cardiologist from Vancouver, who happens to be a good friend of mine and professor, and was actually visiting today for another innovative procedure that we did in the cath lab. This condition is called a spontaneous coronary artery dissection. It's a complicated name, but what it stands for is a young woman, and predominantly is seen in women, who is an athlete and otherwise healthy and doesn't have any cardiac risk factors, could develop a heart attack, and it's due to a shredding of a coronary artery because the artery is very soft and usually happens again under extreme exertion or stressful situation. There is no cholesterol buildup and no plaque formation. This is something that in the past we never saw because we didn't have the imaging techniques and the technology to recognize it. But even around Christmas time, I had a young athlete, lady in her early 50s, who came into the cath lab with acute coronary syndrome and had this type of shredding of the artery. These are events that we now recognize in women, and we started taking more seriously women's symptoms. The other thing that's very interesting about women is that women somehow are wired differently than men. So a lot of the symptoms that women experience are not the typical symptoms that we saw in the 60s when we described the original symptoms of a heart attack or angina. Some women complain of fatigue or low energy, and that could be the first sign of lack of blood supply to the heart muscle. Other women have pain in the back or between the shoulder blades, and some of them experience pain in the neck or in the back of the neck, which again quite often is confused for some musculoskeletal pain. Women are sent to chiropractors or physiotherapy. And what is the important thing about it is that why women die more than men from heart attack? Well, because their symptoms are not the traditional symptoms described for men, and then they seek help later than men, and a lot of the times a damage has already been done, or the damage is ongoing and other treatments are being given that are completely different than the treatments necessary for lack of blood supply or heart attack. So for me, the most important thing is that we're all here together to talk about it. I didn't prepare any slides, I didn't bring any papers because I'd like to talk to you and hear from you if you have any questions. But the most important thing is for you as women and the men in the room who are the family members, the loved ones, to recognize the symptoms of a woman's heart attack. It's not always the traditional chest pain. It could be sweating, it could be nausea, it could be lightheadedness, fatigue, back pain, neck pain, jaw pain, tingling in the arms, radiating to the shoulders. If you recognize any of these symptoms and they're unusual, you never had them before, you never had any diagnosis of any condition that could cause these symptoms, think about heart attack. If you feel very short of breath or extreme sensation of impending doom, please ask for help. If you recognize any of the symptoms of a heart attack, the first step is to try to settle down and talk to someone and ask for help, someone that's close by. There is a very important message that I want to pass on to you, and it's to be aware of the symptoms and how to call for help. So that's the next step that I want to talk about. A lot of the times, the traditional therapy is nitroglycerin for people who have access to it, but a lot of patients are not aware or they don't have preceding cardiac conditions. In that case, simple aspirin will be helpful. By chewing large aspirin will at least release some of the formation of clot and give you some time to call an ambulance. If you recognize symptoms of a heart attack, the next step is to call 911 and call for help. I'll tell you why this is very important. A lot of the heart attacks that are diagnosed on the scene by an ambulance are recorded on an EKG. If it is a serious heart attack, we here in Winnipeg have a program called the Code STEMI program. It's served by cardiologists, and I'm one of them. It's on an iPhone. And what it does is, if you feel that you're having a heart attack and you call an ambulance and say, I think I'm having a heart attack, they will dispatch a crew that could perform a 12-lead EKG on you, and they could recognize immediately that there is a heart attack. At that point, they call one of us who is on call, and it's a 24/7 service where we read the EKG immediately. So within 2 or 3 minutes of the ambulance there, we could diagnose a major heart attack, and from my phone I could activate the cath lab and call in the team to come in and do an angiogram within the next 15 to 20 minutes of the onset of your symptoms. So this, when we looked at it in our research in our cath lab, it was first initiated in 2009. And since then, there's been a lot of work done, and a lot of us have tried to improve that service, especially reading the EKGs at the scene. It reduced the mortality from heart attack in Manitoba dramatically over the last 7 years. So that's why I want to talk to all of you. If there is any sense of emergency, of pending doom, of chest pain, whether you're a woman or a man, call 911 and make sure that someone comes in right there to help you. Don't drive yourself to the hospital, because that could cause extreme delay, and sometimes you could actually have a cardiac arrest en route to the hospital. The other message I want to pass it on, and it's very important, is for all of you to try to educate yourselves in doing CPR. CPR, immediately when you see someone collapsing and we suspect a heart attack, is a very serious life-saving procedure. As we heard, it only takes 3 to 5 minutes for the brain cells to die without oxygen. And if we only learn to put pressure on the chest when we suspect that there is a heart attack, we could save their loved ones and actually bring them back to life. So this is something that it is really, really important to be comfortable with and not be afraid to perform as soon as you recognize it. The last thing I want to say is that women are becoming more aware of conditions related to their heart, and there is still a lot to be learned. So when you are invited for research opportunities, when you could participate, it's not only that we learn about the future and what will happen and what else we'll discover about our hearts, but also is a very beneficial step for your own health, because participating in research, being part as a patient or a volunteer in research programs, really helps you understand your own heart and your own condition. Allows you to communicate with other people and specialists and be part of a community where then you learn and communicate to your friends, your families, and children about women's heart, and the subtleties of that are still yet to be discovered. Thank you very much.
I think you were asking, we hear a lot of talk about Lipitor and various other statin drugs. What's the latest thinking on that? Are they useful or not?
There have been multiple trials performed on statins. Again, statins are basically used in secondary and primary prevention of atherosclerosis. For patients who were diagnosed with coronary artery disease, they're absolutely mandatory, as they would prevent future progression of coronary artery disease. In patients who had previous stents or coronary artery bypass grafting, they're also an important part of their therapy. A lot of the times, patients have a real hard time with side effects from statins, and the major ones are muscle pains and aches in the body. There is a revolutionary therapy that's on the horizon, and the group of these medications is called PCSK9 inhibitors. What they do is they work together with statins, and they reduce the bad cholesterol to almost zero in your blood. There are no actual trials developed for them yet as far as randomized trials, but the initial trials for safety and usage have been proven to be that these medications will allow you to reduce the dose of statin, with which you reduce the side effects of the medication like Lipitor, but it allows you also to maintain very low cholesterol. This medication was just approved a month ago on the market in Canada, and it's an injection form, and right now is approved for patients with familial high cholesterol, so young patients who are at high risk of developing coronary artery disease. It's being given as injection twice a month, so biweekly injections, and the name is Repatha. But again, this is a medication that is still yet to be discovered. There have been a lot of concerns about developing diabetes with statins, which I really encourage my patients not to worry about it too much, because we have a lot of data and evidence that statins delay plaque progression and really are an important part of the also inflammatory pathway of coronary artery disease and acute coronary syndromes.
As someone who's taken Lipitor for 13 years, I think I suffer some of the side effects of it. What did you say the name of that just approved medication is?
Well, I'm not here really to advertise, but the reality of this is that it's really not been proven in randomized trials, but all I want to say is that there are new medications on the horizon that may combat some of the side effects.
Good news. Anyone else with a question? There are, by the way, microphones at both sides, but if you're right in the front, speak up. Yes. Rest of the room.
The question is, as a diabetic, for how long you could stay on metformin, and are there any new medications there that may be more beneficial? So there is a group of new medications that was just presented at the European Society of Cardiology conference last summer, which showed a reduction in cardiovascular events. Again, I'm not going to say the names of these medications, but if you go to your family doctors, you'll be able to talk to them about it. It's similar to metformin in a way that it reduces the glucose in your bloodstream by excreting it more through your urine. And it has a pathway that actually, in this particular trial that they presented, reduced cardiovascular mortality in diabetic patients. So again, a lot of the oral antidiabetics, different than metformin, have also shown increased risk of congestive heart failure because there is retention of fluid when you take it. So it's a fine balance, but this new generation does not have that, at least probably because it has not been around for long enough to create that interest in that trial. But there's definitely other medications out there that you may be interested to consider in addition to metformin. Metformin is still the mainstay.
And there are people up in heaven there that can ask a question as well. We have a question from down in the front. Yes, go ahead.
But is still there.
Broken heart syndrome.
So this is a question about broken heart syndrome?
So broken heart syndrome is a syndrome that was recognized about 10 years ago. It's also known as Takotsubo cardiomyopathy. It stands for, Takotsubo is the Japanese word for an octopus trap, All it is just a pot that traps the octopus in and then it doesn't let it out. And that's the shape of the heart that we observe when someone presents with broken heart syndrome. The usual presentation is acute events, so bad news is the big one that could trigger chest pain and typical symptoms of heart attack. And patients end up coming for an angiogram on an emergency basis, and when we do the angiogram, we don't see any coronary blockages. And the only thing we see is when I take a picture of the heart that it looks like this takasubo, or a big ballooned up heart. It was a mystery for many years, and then after MRI was introduced, like you saw on the presentation, we were able to see that it's a microvascular event, and all it is caused by is a spasm and vasoconstriction of the microscopic blood vessels of the heart. And as it causes that, it causes microscopic damage in all the small muscle cells in the area. The good news about it is that it's reversible, so once the stressful event is gone, with proper medical therapy, the heart could regain its normal shape and come back to normal size. And the only bad thing about it is that it could reoccur. So we always tell women that had that to prevent any possible extreme excitement. In fact, it's been documented in positive emotions too, so it's not only negative, but the more common thing is a woman, usually in women, and usually bad news. So someone dying in the family or a huge argument are the things that trigger it.
So it's not caused by failed relationships then? Could be, perhaps.
It could happen. It could happen.
I mean, we certainly sing a lot about it, don't we?
The question is, if a woman has a heart attack, do her enzyme levels change the same or similar to a man? The enzyme levels change due to the damage of the muscle cells of the heart. So the amount of enzyme release is correlating to the amount of damage to the heart cells. Depending on the size of the heart attack, there could be very high levels of enzymes and not so high. And I don't think that there is specific difference, or at least I'm not aware of something. It's all related just to the size of the heart attack.
Another question. Yes, speak up. Go ahead. Yes, please.
My husband takes low-dose aspirin. When I went to see my doctor for my appointment, he said that in the last 10 years they are not suggesting that anyone takes low-dose aspirin anymore. So, what do I do about low-dose aspirin?
There has been a lot of talk about aspirin causing gastrointestinal bleeding, and that's why we've been so concerned about offering it for primary prevention. So there's a lot of discussion about that. Primary prevention means someone that has never had an event and has no risk factors, and the recommendation is not to take it. But for anyone that has had a heart attack or had documented blockages in their arteries or a stroke, that's a recommendation. So talk to your family doctor, and they will perform a risk stratification, so they'll do a calculator and see if you qualify for aspirin or not. Again, the calculator we use is called the Framingham Risk Score, and that was a study performed in the 60s and 70s, and it was mostly men. So now we're questioning whether that is really applicable to women, and that's a whole another talk we could give on another night.
There is, by the way, a fascinating book about the Framingham Heart Study, which was the first major initiative in the United States to chronicle the occurrence of heart disease in an entire community for decades. Still going, in fact. Great book. It's in the library. Yes, your question.
How do you sign up for the Happy Hearts?
How do you sign up for the Happy Hearts? Terry Moffat can help you with that. She's right here. And there was another question. Yes? Okay. Oh, sorry. Excuse me. Terry, go right ahead. Excuse me.
So Happy Hearts, you can email us at happyhearts@sbrc.ca, or you can phone us at 235-3589. And Ivan does have a poster where we have rip-off, so
Yeah.
we can give you one of those.
Ivan's in the back of the room. He's got the little slip of paper with those details on
Yeah,
it.
exactly. Does anybody else have any questions about Happy Hearts?
Yes.
Everybody knows who Ivan is?
I think it
Ivan,
might
can
be
you
better
stand
to
up?
come Jim.
I'll get the posters as well, and I'm wearing a very bright red shirt for the heart awareness, so.
In case anyone is interested in the project the First Step project that I mentioned, if you are someone who has had, a woman over the age of 50 who has had a cardiac event or cardiac surgery, and you, for whatever reason, have decided that you did not want to go to or could not go to cardiac rehab, you may qualify for our project as well, so I'll put in my plug. And I have a phone number for you, and it is 477-3541. Or if you call the foundation, if you don't get the number and you call the Victoria Hospital Foundation, they will direct you to our research coordinator, whose name is Terry. So again, that number is 477-3541. Thanks.
How does the, pardon me, POTS? How does the POTS syndrome affect the heart? Dr. Toleva, are you familiar with that? POTS? Would you like to come up to the mic? Sorry about that.
All right, so it has to do with the regulation of heart rate and blood pressure, and is not associated with coronary artery disease, which I thought was the talk of today's talk. It has to do with dysregulation and palpitations and other symptoms, also common in women, more common in women than men, and also in young individuals.
Another question? Yes.
Raising awareness amongst patients is as important as raising awareness amongst physicians. There is another initiative that I'm part of together with Dr. Dukas, who is the head of the cath lab, called the ACS Network. What we do is we travel around all the towns that have emergency departments in Manitoba, and we raise awareness amongst emergency physicians and family doctors about recognizing heart attacks and calling for help to the cath lab sooner so we could prevent damage to the heart muscle. If you experience any symptoms and you feel that they're related to your heart, I know the emergency rooms are very long waits, but that would be probably the safest place to go, because they will definitely perform at least 2 EKGs and a blood test to recognize if this is an impending heart attack or if there is any potential sign of lack of blood supply to your heart.
Dr. Toleva, one term you used, and I've heard it used elsewhere, is that one of the symptoms that women have of a heart attack that is coming is a sense of impending doom. Explain that a bit, would you?
A lot of the times it's related with either low blood pressure or sensation of not being able to take breath and not being able to get enough oxygen. And it feels like you're suffocating and you're dying without being able to do anything about it. A lot of the times when you're having a heart attack, your blood pressure, instead of being really high, is really low, and there is low perfusion to all the vital organs. At that point, all the systems are shutting down, and the body tells you that you're dying. So that is the sense of impending doom.
Okay.
Yes, yeah. EKG has about 50 to 60% sensitivity of recognizing lack of blood supply to the heart. Stress test is another way of diagnosing lack of blood supply, because usually when you're not having a heart attack but building up blockages, you may develop some changes on exertion that would show up on an EKG stress test. Again, the problem is that when they validated the exercise treadmill tests in the 70s, they were mostly validated in older men, so men over 55. So the pre-test probability, or meaning that whether the test will be reliable in a young woman, would be very low. That's why there are other tests, for example, percent in MEB, which is a stress test, a nuclear stress test that was mentioned in the talk, but it involves a lot of radiation. So for a woman, it's probably not ideal. The MRI that was mentioned as a research protocol is not available in Manitoba. It is available in some places like Ottawa and Edmonton as a research protocol. It's called a stress MRI, and it could show lack of supply to certain areas of the heart. Again, it's rare that we have access to it. So we work with what we've got, and usually it would be an EKG test, blood test to check for enzyme rises, checking out cholesterol, stress test involving imaging like a MEB scan, so nuclear stress test. These are the things. In some provinces, there is another modality called a CT angiogram or a CT scan, and that is something that we are developing. We just bought a new CT scanner, so we'll be doing more of that for moderate risk patients. Again, for lower risk patients, things are a bit difficult and different, and a lot of the times young women fall into that category. For example, the situation where I told you about the shredded artery, it's usually young women that are athletes and they're runners and they have no coronary artery disease risk factors at all. And unfortunately, the only way to diagnose that is when you're coming in with a heart attack. Thank you.
And one more quick question. Is anyone funding for a stress MRI for Winnipeg?
I am not aware of it. I'm not an imager, but Dr. Devinder Jassal is our cardiologist that works with MRI, and I'm sure if we ask him that question, we could probably arrange an answer to it. Yeah.
All right. So we have a volunteer to throw in money already. Thank you. Now, we have a few things to conclude the evening, but I wanted to invite Reverend Dr. Sharon Wilson up to talk a little, just to say thanks to all of the people who work behind the scenes to make such a difference. We had the people who were the speakers, but there were many others who just spent a lot of time making sure that tonight was going to happen.
Thank you, Terry, and thank you to all of you. This is amazing. This happened because of Lil. I said she was the tipping point. The latest of far too many women in my career who've found themselves either catastrophically ill or unfortunately deceased with no apparent warning. So I'm hoping we change that trend, and I am so grateful for all the medical experts and scientific personnel who've been here tonight and came absolutely freely, both cost-wise and time-wise. And to Terry MacLeod, who is the living, breathing embodiment of good post-disaster heart health.
Thanks.
You've heard about Ivan Berkowitz, who is a force of nature working out of St. Boniface Hospital Research Foundation, who is a key part of a much larger group of people. So if all of you volunteers on our coordinating committee could just sort of wave your hands now. There's about a dozen people around the room.
Yay.
Doug, our techie for the night, and Bob, our sound man. And for all our daughters and granddaughters, we hope they will live very, very long, healthy lives
We
because
should,
of tonight.
Reverend Sharon, try to form something out of tonight to keep the momentum going. I think there's a lot more that needs to be done, and I think one of the strategies we could do is to teach women not to be so nice.
Have you been talking to my husband?
But a kind of pushback with your GP who may not be entirely up to speed on this and may not be tuning into the specific needs of women. I think women need to become more fierce about this, and those who look at the model of what women did with breast cancer and breast cancer research and the runs for the cure, those are models that could be really usefully followed.
Speak up and don't take that gentle tap on the wrist.
Yes, go home.
When you're told to go home and take it easy.
Right, you have a sore neck, yeah.
Yeah.
Just a little comment. There is an evaluation form
Yeah.
that ended up in the bags that you were given. So, and there are pens in the pews.